Hi, welcome to the University of California, San Francisco hip replacement preoperative session. My name is Lisa Hartmeyer and I'm a nurse practitioner in the Division of Arthroplasty. We're going to run through these topics one by one, starting with the anatomy of the hip, understanding how hip replacement surgery happens, anesthesia, recovery in the hospital, pain management, physical and occupational therapy, risks of surgery, incision care, preparing for surgery, discharge planning, contact phone numbers, and some prescription instructions. We're going to start with the anatomy of the hip. The acetabulum is the cup of the pelvis. The ball of the pelvis is called the femoral head, and that's the end of your femur or your thigh bone. The other parts of the hip are the greater trochanter and the lesser trochanter. Now, in a normal healthy hip, that ball should be covered with cartilage, which serves as a cushion. But in an arthritic hip, as well as other conditions that cause death to that bone or wearing down of the cartilage, you can get osteophytes or bone spurs, cysts that form, and all in all that causes a painful hip and perhaps some decreased range of motion. So now we're going to talk about total hip replacement. Science doesn't have a way to inject new cartilage into the joint or go in and clean out that hip with an arthroscopic procedure in most cases. If your surgeon feels it's best for you, he will have offered you a total hip replacement to provide more longer-lasting pain relief for your hip joint pain. So what the surgeon will do is he'll make a 4 to 6 inch incision and go in and remove the arthritic femoral head and neck. This bone can't be saved due to how damaged it is. Then the surgeon will place a femoral stem, and this is made out of metal. At the end of this femoral stem, there's a ball which will serve as your new hip ball joint. This is an example of what it will look like. The surgeon has already prepared which size he expects to need for you, but he has all the available sizes in the operating room for you if he decides to go up or down a size. Then the surgeon will clean out the acetabulum and place the acetabular component. This is usually made out of titanium, and you can see on here there's a lot of squiggly lines, and that's for the bone to grow in. It takes about 3 months for the bone to grow in. In between the acetabular component and the femoral head, there's a plastic liner, and this is made out of highly cross-linked polyethylene. And what that means is it's very durable, thick plastic. That's going to serve as the new cushion in your hip joint. This is what a completed hip replacement will look like on X-ray, as well as a cartoon version. Understanding hip joint replacement surgery. Your hip implants may be cemented or uncemented, and this is based on your age, your medical history, your bone quality, and this will be determined by your surgeon. The physical therapist will review any weight-bearing restrictions or precautions you may have when you wake up from surgery. And your team will let you know how much weight you can put on your leg depending on what kind of surgery you had. Most of our patients will put full weight on their legs, and we will expect you to get out of bed the same day of your surgery with the assistance of our staff. Anesthesia. So the day of surgery, you're going to check in at the admissions area. Then you'll go up to the pre-op area where you'll change into a gown, and the nurse and doctors will assess you. They'll place an IV in your arm. When the operating room is ready for you, they'll wheel you back, and you'll either get regional or general anesthesia. Most of our patients get regional anesthesia, which is a nerve block in your spine, as well as IV medicine to keep you asleep and comfortable for the procedure. The nerve block in your spine is similar concept to the epidural, like what moms have when they're having a baby. It's usually a one-time dose of medicine so that you'll be numb from the waist down. If for some reason you cannot have this general anesthesia or that spinal nerve block, then they may discuss general anesthesia with you. General anesthesia is anesthetic gases through a breathing tube. It's more heavy sedation. What kind of anesthesia you get is based on your medical and surgical history, which will be reviewed at your prepare appointment. The final decision of what kind of anesthesia you have is up to the anesthesiologist as well as you before the surgery. Recovery in the hospital. The surgery itself takes about 1 to 2 hours per side. After the surgery, you'll go to the recovery room for about 3 to 4 hours. There, the nurse will monitor your vital signs and make sure you're waking up from surgery and your pain is well controlled. After you're fully recovered, you'll go up to the 12th floor, which is the orthopedic floor. You'll stay there for about 2 to 3 nights. I want to remind you that the patients who are on the orthopedic floor are healthy, as are you, in order to have this surgery. Physical therapy will start to see you the first day after your surgery, as well as occupational therapy. We'll talk about the differences between physical and occupational therapy in just a few slides from now. Nurse case managers will also visit you to discuss your needs, in case you need to go somewhere other than home after your hospital stay, or if you need home care such as physical or occupational therapy, or if you need equipment to be ordered for you. Pain and the pain scale. We will give you sufficient pain medication and maintain your safety. We're going to ask you on a scale of 0 to 10, 10 being the most pain you've ever had, 0 being no pain at all, what number is your pain? Our goal is for your pain to be managed so that you can do your physical therapy. We can't promise that you won't have any pain after the surgery, as it is surgery. A few tips that's important for you to know is that we don't want you to wait to ask for pain medicine. We want you to stay ahead of your pain so that you're not chasing it and you don't become too uncomfortable. Speak with your doctors and nurses so that we can manage your pain in order for you to do your physical therapy. Pain management. There's a lot of things that we do to help your pain. Most patients will get a nerve block in your spine prior to the start of surgery, which helps last and control your pain for approximately 8 hours, and it wears off slowly. We also use a multimodal pain management system, which is 3 separate oral medications which are given prior to the start of surgery in the hospital and then continued for 2 weeks after the surgery. These medications are Tylenol or acetaminophen, which is a gentle pain reliever, Celebrex, which is a brand name anti-inflammatory, and then another medication called Neurontin or gabapentin, which is a nerve pain medication. We will not give you any medications you're allergic to or have a contraindication to taking. I want to spend a moment talking about these 3 different medications. They'll be given at different intervals, and they work in 3 different ways to help manage your pain. Tylenol or acetaminophen is a pain reliever and fairly safe to use in most patients. Celebrex is an anti-inflammatory and currently is only available as a brand name prescription. This helps reduce inflammation. It is important to know that this medication, because it is brand name, is often not approved by insurance companies or you have a large copay for this medication. If it is not approved or you have a large copay and can't afford it, it is okay to not take this medication. It will not change the outcome of your surgery. Neurontin or gabapentin is a nerve pain medication and helps with the pain associated at the incision site. We will also offer you narcotic pain medication by mouth, either Norco, Vicodin, Percocet, oxycodone, or Dilaudid, based on what you've used. If you've not used any of these before, the doctors will decide which medication may be best for you. They will tailor a program for you so that your pain is managed. We try not to give you very much narcotic pain medication, as it often causes sedation or other side effects such as constipation. We've also stopped routinely using patient-controlled analgesia, or a PCA, and this is a pain machine which you have hooked up to your IV and can push a button every 10 minutes to give yourself a dose of pain medication. We've stopped using this routinely because it causes a lot of nausea and vomiting postoperatively and is also prohibitive, meaning it won't let you get out of bed if you're feeling nauseous or vomiting after surgery, and it is one of our goals to get you up and moving as soon as possible. Most of the narcotic pain medications have Tylenol in it, or we will be giving you a separate acetaminophen or Tylenol pill. Please do not take any additional Tylenol or acetaminophen while you're taking this regimen, because high amounts of Tylenol can be harmful to your liver or kidneys. The new maximum Tylenol or acetaminophen per 24 hours is now 3,000 milligrams or 3 grams. We will set you up on a pain regimen so that when you're leaving the hospital, you should know exactly what you're taking. If you have any questions about this regimen, please call our office and we'll be happy to assist you. Constipation. Orthopedic surgery causes constipation because you're not moving around as much as you usually do, as well as pain medication causes constipation. We'll provide you with medications to keep you regular while you're in the hospital and at home. These 3 medications that we usually use are Ducosate or Colace, which is a red pill and is a stool softener. Senna is a brown pill and is a gentle laxative. And Miralax is a powder that goes in your drink and provides fiber. We want you to not wait too many days before taking action if you're feeling constipated. I won't be able to call you at home every day and ask you if you've moved your bowels, so please give us a call if you're having trouble. Hip replacement frequently asked questions. Patients often want to know when they can drive again after surgery. You need to be off all the narcotic pain medication and be able to make a quick decision with your legs in order to use the brake. If something happens and you're involved in an accident and using pain medications, you can get a DUI. This is why it's a requirement for you to be off all the narcotic pain medications prior to driving. Patients often want to know when they can return to work. It really depends on your job and your recovery, but in a matter of weeks you should be able to get back to work. It will take patients longer to return to a job which involves climbing ladders than one which would be at a desk. Patients also want to know if they will set off metal detectors. Yes, you should give yourself extra time at the airport. You can also use the body scanner line and they'll know that you have a hip replacement. Physical therapy. The first time you get out of bed, you may feel dizzy or lightheaded. And the reason for this is you've been laying on your back for longer than you usually do, you have pain medication in your body, and you have anesthesia. All of this combined can make you feel lightheaded or your blood pressure can get low, and this can cause you to feel somewhat uncomfortable. Please always call the nurse before getting out of bed. The nursing staff is excellent about responding to the call lights, and they will be there to help you get out of bed anytime you need to do so during your hospitalization. Physical therapy will also assist you with walking with your assistive device, make sure that you can do stairs safely, teach you strengthening exercises, review any precautions if you have them, or review your weight-bearing status if this is applicable to you. Discharge planning. All patients will get inpatient physical therapy, where a physical therapist comes to work with you in your hospital room and in the hallway for approximately a half an hour to an hour on a daily basis. They can work with you on doing stairs and making sure that you're able to use the assistive device correctly. From there, there's 2 choices. You may either go home after your 2 or 3 night hospital stay, or to a rehab or skilled nursing facility. Most patients prefer to go home and are most comfortable at home. However, if there are a lot of stairs in your home or you have minimal support, rehab or skilled nursing facility may be best for you. If you do go home, there are 2 choices from there. Patients may either get in-home physical therapy, where a physical therapist comes to your house usually 2 or 3 times per week for a matter of weeks, or you may go directly to outpatient physical therapy, where you drive or take public transportation to an outpatient physical therapy location of your choice. You may go anywhere nearby to home that takes your insurance. And this will usually occur twice a week for about 6 weeks. Occupational therapy. The difference between occupational therapy and physical therapy is occupational therapy is more focused on your everyday tasks, such as getting dressed and bathing. These tools will be offered to you in the hospital, and you may take home whatever is helpful to you. The first item is a leg lifter. The second item is a long-handled sponge. The third item is a dressing stick to help you get your pants off the ground. The fourth is a shoehorn, a long-handled shoehorn. The last one is a reacher. And the one to the right is a sock aid, which will help put your socks on independently. Occupational therapy will also visit with you during your hospital stay, and they'll help you with any of these items or logistics in taking care of yourself independently. Equipment. Everyone either gets a walker or crutches based on your preference and your physical therapy evaluation. It is important to know that if you've either gotten a walker or crutches in the last 5 years, sometimes insurance companies won't pay for a new set. Please have your support person bring it to the hospital on the day of discharge so that you'll be able to get from your car back into your home with an assistive device. If you've never received a walker or crutches before, one will be provided for you when you leave the hospital. The picture to the left is a 3-in-1 commode. This is optional and most patients don't need it. But if it is needed, it can be ordered from the hospital or purchased prior to discharge. It's called a 3-in-1 commode because it serves 3 purposes. If you leave the bucket on underneath the commode, it is a commode. If you take the bucket out and put it over your toilet seat, it's a toilet seat riser. Or if you put the top down and put it in the shower, it's a shower chair. Most patients don't need this, but if you feel you'll need it, it can be ordered ahead of time. We encourage our patients not to buy any equipment before surgery so we can see what you need, and an assessment can be done by the physical therapist, and then the caseworker can help order the things that you may need in the hospital. Fall prevention. We take fall prevention extremely seriously at UCSF. We need to prevent falls in the hospital as well as at home. We want you to always call for help before getting out of bed while in the hospital. This is imperative because patients may often feel that they're strong enough to get out of bed on their own. However, they may get dizzy when they stand up, or their legs may feel weaker than they expect them to. Some tips to prevent falls are we want you to be careful of the tubes, such as the oxygen or the IV tube that you may have for the first night. We want you to use the bathroom before it becomes an emergency. So if you're working with physical therapy and you're on your way back to bed, it's a good idea to use the bathroom on the way back to bed. Another thing you can do to prevent dizziness is to sit up as much as possible when in bed, so the change from lying to sitting standing isn't so great. We have a saying at UCSF called "Be a hero, get up on post-op day 0." Getting up within 2 to 6 hours of your surgery is beneficial because it decreases your risk of blood clots, improves your quality of life, and decreases your pain, as well as shortens your length of stay in the hospital. Your orthopedic nurse will usually be the one to get you up on the same day of your surgery, and you can get up anytime with the assistance of our staff, even if it's in the middle of the night. Please always call for help before getting out of bed. What counts as early ambulation? You and your nurse can decide about what's best for you based on how well you feel. But we want our patients to get out of bed and just stand up. You may march in place near the bed. You can sit out of bed for about 15 to 30 minutes, or if you feel like walking, you may do so with the assistance of our staff. Go ahead, try out your new joint. We know that there are barriers to getting out of bed quickly, and those may be pain or nausea or dizziness. Your healthcare team, including your doctors and nurses, will work on these issues to avoid delaying ambulation. We really want you to try to get up. You're still a hero even if you try. Please always call our staff before getting out of bed. Things you need to do in order to be able to go home. You need to be able to control your pain on oral pain medications. Get yourself in and out of bed. Walk the minimum distance in your home setting with using either a walker or crutches. If you have stairs in your home, you'll need to be able to demonstrate that you can do these safely. You or your helper will be able to inject the Lovenox blood thinning medication. We will talk about this in a few slides from now. Risks of surgery, we're going to go through these one by one. Infection, blood clot, nerve damage, dislocation, loosening and wear, and leg length changes. The good news is that each of these risks are less than a 1% chance. Preventing infection after surgery. We follow guidelines set forth by the American Academy of Orthopedic Surgeons. The recommendations for taking prophylactic antibiotics or preventative antibiotics before routine dental work or other invasive procedures has recently changed. The American Academy of Orthopedic Surgeons is now recommending that you discuss with your surgeon and care team whether or not they recommend taking antibiotics prior to dental work or other invasive procedures. We are no longer routinely recommending taking prophylactic antibiotics before dental work. However, you may discuss this with us in the office, as well as with the dentist. Incision care. You'll either have staples or sutures. We want you to keep the incision clean and dry until the staples or sutures are removed at approximately 2 weeks post-op. You do need to cover or seal the incision when you take a shower or just do sponge baths while you have the staples or sutures in for that first 2 weeks after surgery. Can recommend using plastic wrap or putting a bag and taping it over the incision to keep it dry while you're bathing. You will leave the hospital with a special dressing called a Mediplex. This should stay on for about 5 days. And it may have some saturation or drainage under the dressing, and this is normal. If after 5 days, or if becomes more than 70% saturated with drainage, you should remove it and then use 4x4 gauze. You may use the 4x4 gauze and change it daily until the staples or sutures come out. This is what the 4x4 gauze will look like out of the package. You do not need to cover it any longer after the staples or sutures come out. Staple or suture removal. The staples or sutures are removed at approximately 2 weeks after your surgery, and they can be done in a variety of different ways. If you live locally, the nurse practitioner or physician assistant can remove the staples or sutures at UCSF Orthopedics at our Mission Bay office. If you have home physical therapy or nursing coming to your house, they can also remove the staples or sutures. If you go to a rehab facility and are there for at least 10 to 14 days, they can remove the staples or sutures there. If you live far away, you can have your local primary care provider take them out. If you are planning on having your local primary care provider remove the staples or sutures, you must set up this appointment for 10 to 14 days after your surgery. Incision care. If you plan on going home after the surgery, you will be responsible for changing the dressing once a day. However, the Replacement1 dressing will stay on for about 5 days after your surgery, and then you should change the dressing once a day after that until the staples or sutures are removed. I do recommend 4x4 gauze and paper tape. So you'll need about 5 to 7 days or 5 to 7 pieces of gauze because the Replacement1 dressing will stay on for the first 5 days after surgery. Some oozing from the wound is normal and it should be decreasing over time. Please do call our office if you have any concerns about increased pain, redness, swelling, warmth, or drainage from the incision. Post-operative swelling is normal. You may have swelling from your thigh to your toes. There's a lot of difference between patients with how much swelling you may have, and this swelling may last up to 6 weeks after your surgery. You may decrease the swelling by elevating your leg and using ice. Blood clots. This is another serious risk of having any surgery. Blood clots can form in the leg and move to the lungs or heart or brain, and we try very hard to prevent them. Signs and symptoms of a blood clot are pain in the calf that doesn't go away, a swollen calf, however this can also be normal, a ropey feeling under the calf where you may feel like a piece of rope is underneath your skin, redness in the calf, a fever, or shortness of breath. If you get shortness of breath and you're not exercising, you need to go to the emergency room or call 911. We try very hard to prevent blood clots, and we use a medication called enoxaparin or Lovenox, which is an injection for a total of 13 days after surgery. You'll get a dose in the hospital once a day for 3 days, and then you'll use 10 at home after surgery. This is an injection into the abdomen once every day. The nurses will teach you how to do this in the hospital. They will also give you a teaching kit from the hospital, which does not contain the medication, but it has a DVD in case you forget how to do it, a sharps box, and alcohol swabs. The medication will come pre-filled in a syringe and will look like this. You should get 10 of these after surgery. If you are already on a blood thinner of any sorts, we will potentially order a different kind of medication for you, and this will be discussed with your care team. We will also have sequential compression devices in the hospital, which are like little pillows that wrap around your legs and help squeeze the blood back up to your leg to the rest of your body. The best way to avoid a blood clot is to be active. We also encourage you to avoid flying for 6 weeks after surgery because this is the time that you're most likely to get a blood clot after surgery. Nerve damage is another potential complication of surgery. Sometimes patients complain that they have some numbness around the incision. This is generally temporary and improves over time. Foot drop is a more serious complication of the surgery, and that is the loss or the decreased ability to bend the ankle or the foot upwards. This is very rare that it happens, and if it does happen, it usually improves over time. Loosening or wear? On average, the implants last for about 15 years. What tends to wear out is the polyethylene liner. If that wears out, that may be changed as these pieces are modular. We encourage you to avoid high-impact activities like basketball or running, as this may decrease the life of the implant. We encourage you to find alternative non-impact and low-impact activities such as bike riding, swimming, or walking as part of your regular exercise. Dislocation. This is very unlikely if you follow all of your precautions if these are applicable to you. Your care team will remind you about which positions you should avoid, and they'll teach you these while you're in the hospital. Leg length changes. The surgeon will do his very best to keep or fix your leg length to be the same. However, there may be a slight 1 to 2 centimeter difference in length. Oftentimes, patients have been living with a change in their leg lengths, and so when the surgeon corrects this, it may feel that the operated side is longer. We urge patients to give your body enough time to adjust to your new hip, and if there is a discrepancy, a shoe lift may be prescribed, but only after very many months if the leg lengths are truly unequal. Preparing for surgery. Which medications you will need to stop or continue will be reviewed with you at your prepare anesthesia appointment. We would like you to stop taking medications that may increase your bleeding 7 days before surgery, such as over-the-counter anti-inflammatories like ibuprofen, Motrin or Advil, naproxen, or Aleve. You must also stop taking glucosamine, garlic, ginkgo biloba, ginseng supplement pills, vitamin E and fish oil, as these medications tend to thin your blood. You may continue to take Tylenol, Celebrex, or narcotics up until the day of surgery if you are already taking these. Preparing your body for surgery. You may increase the iron in your body prior to surgery. Sometimes patients like to start over-the-counter iron supplements. However, the best way to get iron in your body is to eat food rich in iron, such as green leafy vegetables, meat, or beans. Continue doing this for 1 month after your surgery. We also encourage you to maintain your current level of fitness between the time you decide to have surgery and your surgery date. What to bring to the hospital? Please bring a list of your medications on paper so that we can make sure that you receive the medications that you normally take at home. You may also bring books and magazines to keep you busy while you are resting. Also, wear a set of comfortable clothes and shoes to the hospital so that you may wear these either while doing your physical therapy in the hospital or on your way home. Don't bring your own medications to the hospital. The hospital will provide all of your medications that you normally take. Leave your cash and credit cards at home as well as your jewelry. We urge you not to bring too much to the hospital, as you will only be with us for a short period of time. Most of our patient rooms have large TVs in them, and you may also borrow laptops if needed. Please put your name and date of birth on all your personal belongings so that we can get it back to you if it becomes separated from you. Preparing your home for surgery. Remove anything that you can trip over. You may want to rearrange the furniture, such as pulling a coffee table out from the couch so that you have room to get through with either your walker or crutches. You may feel like having prepared food at home that can be easily available, such as microwavable food, or some things that are easy to get to. Please make sure you have a ride home from the hospital and someone to help pick up your medication. Sometimes pharmacies deliver. This may be helpful to you in your recovery. Sometimes pharmacies deliver. This may be helpful to you in your recovery. Preparing for surgery. We would like you to take a shower using a special soap called Hibiclens. This special soap will be given to you in the clinic, and instructions will be included on how to use it. We would like you to take 3 washes starting 3 days before surgery and wash daily, including the day of surgery. Please wash your body with it from the neck down. Avoid putting it on your face or genitals, and do not put on any lotions or deodorants after taking your shower. It is also imperative that you stop eating and drinking the midnight before your surgery. It's a good idea to review your surgery information and take any routine medications with a sip of water as instructed by our prepare staff. Contact phone numbers. Please call our clinic anytime if you have any questions. We want you to have a very successful recovery, and we're here to help you if you have any questions. When you do call, please leave your name, your phone number, and date of birth every time you call so we can get back to you in a timely manner. After hours, weekends, and holidays, please call the answering service if you have an urgent orthopedic issue that cannot wait till the next business day. That phone number is 415-353-2808. If you have an urgent issue that requires immediate attention, you can call this number and ask to be connected with the orthopedic surgeon on call. He or she may help you answer your questions if it is an emergency after hours. Prescription instructions. Upon discharge from the hospital, you'll be given a prescription for the pain medication you had been using in the hospital on a special piece of paper. This special piece of paper is called a triplicate. You will need to stop on your way home and have this medication filled at the pharmacy of your choice. When you need a refill of this pain medication, please call our office with at least 4 days advance notice, as these medications cannot often be called or faxed into the pharmacy. We will be able to mail you the paper prescription to your house, or you can pick it up from our Mission Bay office. It's very important that you call us with at least 4 days advance notice if you need a refill to be mailed to you, as this is how long the mail often takes. Thank you for choosing UCSF for your total hip replacement. We are enthusiastic to work with you and are excited to get you back to doing the activities that you've been unable to do due to your hip pain. If you have any questions regarding the content in this video, please call 415-353-2808. We'll be happy to help you.